Hello, everyone. Welcome. I'm going to let people filter in just for a minute here. And then we will go ahead and get started. So hello, and welcome to our boot camp, Harnessing the Potential of Oxidative Stress Testing. I am Dr. Kim Bruno, and I'm the Clinical Director of Outreach here at Vibrant, and I'm going to be your host for the next 6 weeks of this boot camp. The format of our boot camp will be live sessions every Thursday at 12 noon Central, and replays and slides are going to be sent to any registered providers within a day of the session. Just to review a little bit of the what's coming ahead is this week we have Dr. Stagg, and she's going to be talking about general concepts of what is oxidative stress and linked to chronic disease and longevity. And then the next 2 weeks, you will be with me, and I'm going to have talking about the genetics of oxidative stress pathways, and then the damaged markers and associated conditions with the particular damaged markers. Weeks 4 and 5, we have Dr. Jason Chen. He's going to be talking about oxidative stress and cardiovascular health in week 4, and in week 5, oxidative stress and hormone and endocrine health. And then we're going to wrap it up in week 6, going over cases, pearls, treatment options, all of that kind of fun stuff to bring it back together. Lastly, I want to go over a couple housekeeping items, and then I'm going to hand it over to our featured speaker. So for today, you are all in listening mode. If you have questions during the presentation, please submit them as a comment. There's going to be time for Q&A at the end, and we will go through all the comments at that time and address your questions. So without further ado, let's go ahead and present our featured speaker for today. So Dr. Jennifer Stagg is a practicing naturopathic physician and the founder and current medical director of Whole Health Wellness Center in Connecticut. She's the author of Bitter Prescription and Unzip Your Genes and is routinely featured as an expert guest in the media. Dr. Stagg's area of clinical expertise include digestive health, mental health, weight loss resistance and nutrition, healthy aging, nutrigenomics, and metabolic and endocrine disorders. She's always been passionate about science and health and has started her doctoral student at biochemistry at the University of Iowa. Dr. Stagg is a former director of the USDA Agriculture Research Service Medicinal Botanical Program in the Mountain State University, and a medical editor for Journal of Herbs, Spices, and Medicinal Plants. A sought-after speaker and media expert, Dr. Stagg has been frequently interviewed, having appeared on major networks, and also serves as the on the scientific advisory board as a medical educator and an industry advisor. She maintains an active travel schedule, educating other healthcare providers on innovative strategies for patient care. We're very excited to have Dr. Stagg with us today. And so I'm going to go ahead and hand it over to her to start off harnessing the potential of oxidative stress testing.
Hi, thank you so much for having me. I'm really excited to talk about oxidative stress, and I would definitely view that as one of these innovative strategies for patient care. So I'm so excited that Vibrant is offering this whole series of webinars that I think we're going to learn so much about it. So I'm excited about the coming weeks as well. Today, I am going to focus on oxidative stress from a clinical standpoint. As you just heard, I do have a very active clinical practice. So this is what I work on every day in practice. I was there all morning today. Here is sort of an agenda for today's webinar. We're going to talk just generally about oxidative stress, how it's foundational in many chronic conditions, some of the pathways affected or promoted through oxidative stress, and then look at sources of free radicals, both endogenously and exogenously. I'm going to just touch on a little bit with genetics and oxidative stress because we're going to hear all about that and then coming weeks. And then we're definitely going to cover a little bit about aging and oxidative stress, how that links to longevity and health span. I am going to also talk about oxidative stress and the relationship with inflammation and when to think about oxidative stress over inflammation. We've all, as clinicians, been so focused for many years on inflammation as an underlying cause of chronic disease in many of our patients, but it really has occurred to me that oxidative stress is probably equally, if not more important than inflammation. And I'll talk about some of that later in this presentation. And then I will talk about clinical considerations in addressing patients who have excessive oxidative stress. I know if many of you were on the last webinar about oxidative stress and the new test profile that Vibrant has, I know there were questions about like, well, what do we do about this? We can do this test. What do we do? I am going to talk about that today. So let's start off just with a brief overview on oxidative stress. And essentially what that is an imbalance between the formation of reactive oxygen species, so ROS, and the antioxidant defense mechanisms that we have innately. And that can result in damage to cells and ultimately to biological systems. So how does that sort of interplay with the presentation of chronic conditions in our patients? So we do know that oxidative stress increases with age. And as I just mentioned, when we have oxidative stress, we can have cell damage, and that can affect tissue function and ultimately system function. So many of the conditions associated with aging, like cardiovascular disease, which, we're going to hear a lot about cardiovascular disease and oxidative stress, diabetes, cancer, Alzheimer's, neurodegenerative conditions, those have been clearly shown to have a direct relationship with oxidative stress. So for many of you, like myself, most of what you hear about these conditions is more inflammation, inflammation, inflammation. So I want you to start thinking about most chronic disease as an oxidative stress pathway as well. Imbalance in these oxidants is, as I mentioned, is what causes cellular damage. Now, what the thinking is that it's more a failure of the innate cellular antioxidant defense mechanisms that is at fault here. And we're going to get into that in this presentation about what we have endogenously to help us balance out production of oxidants in our system and how we rid ourselves of those. So most of that defense is through antioxidant enzymes using their substrates to reduce oxidants. And I do have some slides on that. But first, let's just talk a little bit about reactive ROS and how they're formed. So that is a natural process in the body. Normal cellular processes like aerobic respiration are creating these oxidant molecules. Inflammatory processes that are, our defense mechanisms, macrophages make ROS to kill pathogens. So this is part of phagocytosis. Macrophages also, not only to kill pathogens, will make ROS in response to triggers of inflammation. So chronic inflammation, and we'll definitely talk about this a little bit more. There's so much interplay here, but chronic inflammation through the macrophage primarily creates these ROS molecules. And then, of course, we have diet and lifestyle where we can get exposed to oxidants, a lot of different potential exogenous oxidants coming in. And that may be through heavy metals, environmental toxins, mycotoxins, a lot of dietary triggers. Again, we'll get to that. So when we think about how oxidative stress is at play in disease states, there are a lot of papers on this topic. And I just took two major illnesses that we certainly deal with in integrative medicine practices. So cardiovascular disease, atherosclerosis primarily, is really well detailed as triggered by oxidative stress. And that can cause endothelial cell proliferation, vascular smooth muscle cell proliferation, and vasoconstriction. So this whole concept of endothelial dysfunction as the initiator and progressor of atherosclerosis is triggered by oxidative stress. And again, you're going to hear a lot more about this particular mechanism and pathway for that condition. Also, another major condition we deal with are patients with autoimmune conditions. So some of the mechanisms here involve these post-translational modifications of proteins because of oxidative stress. So oxidative changes will damage proteins, lipids, DNA, and these modifications can give rise to what we would call neoepitopes, and those are recognized as non-self, and then the resultant formation of autoantibodies. So that's another mechanism where oxidative stress is at play in chronic disease. So there are a lot of conditions associated with oxidative stress, and I just took the ones that on this list have very strong evidence. And aging is on that list: sarcopenia, frailty, autoimmune conditions, which we just talked about, and cardiovascular disease, but cancer as well. Lung disease, there's a lot of data on chronic pulmonary obstruction, so COPD, lung cancer as well. Quite a bit of research on oxidative stress involved there. Macular degeneration, another huge category that we deal with in clinical practice, metabolic diseases, so diabetes and fatty liver. So oxidative stress, you really want to think about that in these patient categories. And these, as you're seeing patients with these conditions, I want you to start thinking about it through that angle, through that lens of oxidative stress. And now we can test for this. So that's what's super cool about this new test. Neurodegenerative disorders like Alzheimer's and Parkinson's disease, psychiatric illnesses, depression, bipolar disorder, schizophrenia, even papers on that. And then renal disease, a lot of papers. So I'd say most of the papers that I've read are on renal disease, metabolic disease, cardiovascular disease. Those are like the really big ones that you're going to see, but the papers continue to add in. It's a lot to keep up with. How does oxidative stress cause tissue damage? So as I mentioned, oxidized molecules of lipids, structural proteins, enzymes, and nucleic acids, those are essentially damaged, and that leads to altered cell function and ultimately can cause cell death. Another thing that can happen through oxidative stress and oxidative damage is aberrant redox signaling. So oxidants like hydrogen peroxide molecules, for example, are signaling molecules. Nitric oxide is a signaling molecule, and you need to have a correct balance. This is almost sort of similar to the concept of homeostasis, like being in balance is really important here. So when you have oxidative stress, it's an imbalance in the oxidative load, that we need a little bit of it, but too much is a bad thing. So other electrophiles, they can act as these second messengers. So what happens with tissue damage is you have abnormal signaling that's happening with excessive oxidants. So with the antioxidant response that we have innately, most of that is happening through a triggered process through a molecule called NRF2. And NRF2 is a signaling molecule that works in the cell and is triggered through both pro-oxidants that we're producing in our body, like hydrogen peroxide and electrophiles. And then also another thing that triggers it is phytochemicals. So that's a pretty cool thing, that phytochemicals in our diet, things like sulforaphane, curcumin, I'll give you a little list here next, will trigger the transcription of antioxidant and ultimately phase 2 genes as well. So those both sit on that same part on the genome. And then the antioxidant response element is a mediator of those genes through that pathway. So here are some phytonutrients that modulate the endogenous antioxidant network via NRF2. And again, like NRF2 is a transcription factor that activates that antioxidant response element, which is that gene promoter sequence. So here are some phytonutrients: betanin from beetroot, curcumin from turmeric. Oh, that's a typo, I realized there on that chart. So curcumin obviously would be from turmeric, sulforaphane found in high levels in broccoli, EGCG in green tea, resveratrol from grapes and found, in good concentrations in red wine, ashwagandha compounds found in the ashwagandha root, and then quercetin found throughout the plant kingdom, but high in plants like elderberry, buckwheat, onions, garlic. Those are all modulators of the NRF2 pathway. So these endogenous antioxidants that get upregulated are in two categories. So we have enzymatic antioxidants and non-enzymatic antioxidants. So when we're looking at the enzymes, what we're looking at specifically are superoxide dismutase, catalase, glutathione S-transferase, glutathione peroxidase, and thioredoxin. And then the non-enzymatic pathways, we're familiar with a lot of these molecules and can actually be supplemented. Glutathione, CoQ10, uric acid is actually a non-enzymatic antioxidant. Albumin, bilirubin, we don't necessarily think about that as an antioxidant. Melatonin, again, another molecule or hormone not thought of as an antioxidant. And then alpha lipoic acid. So when we consider where these oxidative stress burdens are coming from, they can come both from within the body and from outside. And as integrative providers, we're certainly doing typically a pretty good job at getting a good medical history, good social history to understand what exposures a patient may have. So when we think about exogenous exposures, oxidative stress could come from medications. It can be from environmental toxins, and certainly there's plenty of those, and we can assess for those as well. Ionizing radiation. Alcohol is what causes oxidative stress. UV radiation, cigarette smoke, of course, would cause oxidative stress, and that is a lot of what's going on with lung cancer and the pathogenesis in lung cancer, combined with genetics, of course. And then inflammation. So a lot, that's just such a broad category. But there are exogenous triggers of inflammation, but of course, inflammation would be considered an endogenous source of oxidative stress. And then just metabolism in general. So high levels of glucose in the body can cause oxidative stress as well. And we'll talk about how that happens. So when we have oxidative stress, as I mentioned, we're going to end up with damage to cellular components, lipids, DNA, RNA even, and protein. And what's cool about the testing that is available now is that we can actually quantify how much oxidative stress is happening in these different categories. So you can see over on the right side of the slide, all of these different markers. And for any of you who are familiar with doing like organic acid testing, really the primary oxidative stress marker we've had so far is just that 8-hydroxy-DG, which is a marker related to DNA damage. But now look at this list. We have so many markers for protein damage, many markers for lipids, more markers with DNA and RNA. So really exciting to actually have these quantifiable measurements to look at how much damage is occurring from multiple sources of oxidative stress or ROS. Here's just one example, heavy metals, a major source of free radicals. So this guide in a paper here cited is mentioning how DNA damage can be the result of exposure to heavy metals. And then this is another big exposure that would be at play in a lot of our patients when we think about inflammation and hyperglycemia and the resultant advanced glycation end products. We just think inflammation, but we should also be thinking about oxidative stress here, because when you have high levels of ages, you end up with ultimately high levels of ROS as well. And so result in oxidative damage, which again, we can measure. So again, when we look at patients, we need to think about their lifestyle, as mentioned, but also their genetics. And I think we do a pretty good job in our field looking at both of those. And so this is two sort of presentations that like we could think about for a patient. So On the one hand, you could have a patient who has a very healthy lifestyle, a non-smoker, non-drinker, getting regular exercise, lots of sleep, enough but not too much, managing stress well, having, an excellent diet, and then they have bad genetics. And we can test for that as well. So this can help to explain why a patient might have more oxidative stress if their diet is all in check. On the other hand, you could have a patient who is doing a really poor job of managing their lifestyle, yet they have good genetics and they're keeping their oxidative stress in check. You always get these patients who don't take good care of themselves, and you think they would be less healthy than they are, but we've got good genetics here at play. And again, we can measure these things now. So the oxidative stress theory of aging, I want to talk about a little bit because it does sort of play into the balance of inflammation and oxidative stress. And we'll talk about that next. But in terms of aging, the theory related to that, it was first proposed in 1956, and it was called the free radical theory of aging. And what the hypothesis is that it's more structural damage based. And so, as I just reviewed, those molecules that are damaged, the lipids, DNA, and proteins, are experiencing functional losses, and that's as a result of oxidative damage. And as kind of the next step in is that these increased levels of RONs, I didn't mention that yet, but there are reactive oxygen and nitrogen species. They lead to senescent cells. And so we know that senescent cells are really critical in the aging process, and we want to limit the amount of those. And certainly there are pathways now to get rid of senescent cells through things like autophagy, stimulating autophagy. But this is a physiological mechanism where the cell has irreversible kind of phenotypical profile, and it's secreting factors involved in inflammation. It's creating a lot of different enzymes and extracellular matrix components. So it's really interesting because we were referring to aging as more so inflammaging, a lot of talk about inflammation, but now the kind of buzzword is oxy-inflammation. So involving both processes. So it does get pretty complicated. They're present in most chronic diseases. The inflammatory cells are activated, as I've mentioned. They release large amounts of ROS, and that can cause overwhelming oxidative stress and result in tissue damage. That's pretty clear. To worsen the situation, excessive ROS on the other side could initiate a cellular signaling that leads to genetic expression of inflammatory mediators. So it's sort of like a back and forth, almost like chicken or egg, which one is causing which. And that's ultimately, what you can test for and start to figure out through process of elimination, through understanding, what your patient's exposures are. All of this really comes in as really key here. Little bit of a paradox, but easily explained. Similar to inflammation, a little bit is good, but too much is bad. ROS is a natural process needed. For example, phagocytosis to kill microorganisms, ROS-induced apoptosis for damaged cells. Just like we talk about with inflammation, it's a natural process. It is designed to protect the body. However, too much of it, when it goes unchecked, it can create disease and chronic diseases. Quite some time back, there was this hypothesis proposed by Watson and Crick, the discoverer of DNA structure. And his proposal was that chronic disease was caused by a failure to generate sufficient ROS, and as I mentioned before, redox signaling. This was a insufficient redox signaling. I don't necessarily think that that's been proven. It seems more the other side, that it is probably excessive production of ROS and the resultant oxidative stress damage to molecules. So the role of NF-kappa B, I just want to touch on. NF-kappa B, just like we talked about NRF2, NF-kappa B is a transcription factor that regulates inflammatory cytokine genetic expression, like upregulation of that in enzymes. And NF-kappa B is what you hear about all the time with like inflammation, various molecules that are NF-kappa B blockers, or even medications that can block NF-kappa B as being helpful for lowering inflammatory load, reducing inflammation. So H2 hydrogen peroxide does activate NF-kappa B, and antioxidants block NF-kappa B. So again, that makes sense, of course. A little bit, kind of dichotomy here is the NF-kappa B subunits are needed to resolve inflammation and relieve oxidative stress. So that is another key player, and it sort of plays into the same concept of having too much of a good thing is a problem. So there's a reason why their NF-kappa B is there. It's helpful to resolve inflammation, but when it is excessive, it will cause problems. And again, like NF-kappa B is related to inflammation and oxidative stress. So combining the dual concept of considering both of these processes now. So I'm sure you're interested in getting to clinical considerations in understanding all of this and how this plays out in a clinical practice. Like, how can we use this information and treatment plans and approaches to treating patients? So oxidative stress, I think you're gathering. I think it comes to play that it is probably just as important and possibly even more important than inflammation. So we're missing the mark if we're not thinking about oxidative stress in chronic disease management. And for so much of our clinical careers, inflammation has been like easy to measure. We can test CRP, we can test SED rates, we can test it, like even interleukin molecules, prostaglandins. So a lot of these markers for inflammation are easily tested through, conventional labs. However, now we have the ability to test oxidative stress. And you may have found that in some of your patients with really well-established inflammatory disorders, you go ahead and you test their inflammatory markers and they're fine. They're in normal range. And it's somewhat confusing. Now, there is the kind of concept that there's inflammation in the tissue space, and there may not be as much inflammation always detectable in the serum. So there's a component of it there. But certainly I've had patients who in this next statement don't respond well or as expected to inflammatory targeted treatment. So, you can give them something that is very specific for inflammation that works on another patient with similar symptoms or conditions and profile, and it doesn't work very well. So these are the types of patients you really want. I would say consider oxidative stress in any chronic disease patient, but definitely start to think about these patients who didn't respond well. And there's so much interplay between the nutrients that help with inflammation and those that help with oxidative stress as well. So there is a lot of crossover here that you can use and cover both essentially. Now, of course, yes, this is complicated. Trying to treat the root causes of an inflammation or an inflammatory condition that can be driven by oxidative stress. And then that involves targeting endogenous and exogenous sources of reactive oxygen species. And that would include inflammation itself. So a lot to consider, of course, but like it's breaking it down simply. There are easy ways that you can look at, as I mentioned, all these different endogenous sources and exogenous sources of oxidative stress. So let's look at oxidative stress in these in a couple of different conditions. So in long COVID, actually, there have been quite a few papers. I just pulled a sampling of some of the better papers or more impactful papers on oxidative stress here. And this paper from Frontiers in Immunology published last year stated that COVID-19 and diabetes are recognized as oxidative diseases. And that is, the authors propose, is why that there are worse complications seen in diabetics because of this concept of synergistic oxidative stress, which I find really interesting. And then the redox in another paper published in PNAS in 2021 talked about the redox imbalance as a pathology. Remember, I mentioned there are two possible or different ways that tissues can get damaged: direct oxidative damage through lipids, DNA, proteins, but also through redox signaling abnormalities. And so this was what was discussed as pathology in patients with COVID, or have developed what could be called chronic fatigue syndrome, but ultimately is an issue with long COVID and oxidative damage. And then another paper in Frontiers of Pharmacology in 2022 looked at patients with COVID-19 and found them to have a really severe deficiency in vitamin C. I think there were multiple papers on that. And then using high dose IVC had been shown to reduce risk of severe complications. But what I want you to take away from that paper is some of these statements about how oxidative stress and inflammation were involved in the development and progression of the fatigue, neuropsychiatric symptoms by disrupting tissue, autoimmune processes, development of autoantibodies, blood flow, so immune thrombosis, all the things that we were saying, and even neurotransmitter metabolism affected. In my practice, we use something called photobiomodulation. Essentially, this is red light and infrared light therapy. We have a full body bed that we use for our patients. And the evidence on PBM is that a lot of the conditions with the strongest positive responses are also those associated with oxidative stress. Now, there's certainly a lot of science on why PBM works in the body. And it's thought to certainly, like a lot of really great papers on neurodegenerative disease, renal disease, psychiatric disorders. We use it for a whole range of conditions in our practice, but it essentially works through, it's of course non-ionizing radiation. It's visible red and near infrared. And it works through free radical displacement and helping to relieve that oxidative stress burden when there is an antioxidant deficiency in the body. So it also increases mitochondrial membrane potential, ATP, CAMP, and nitric oxide, which is a signaling molecule. Again, with this like redox signaling. And then PBM also stimulates mitochondria, cell-mediated cellular processes in these damaged or dysfunctional tissues. So it's pretty cool how it can help to regenerate. We use it in patients with neuropathies. I've used it in patients with stroke for stroke recovery. I have a patient right now getting great results. She's post chemotherapy for inflammatory, like stage 4 inflammatory breast cancer, and has a lot of neuropathy, and everything is like coming back pretty quickly. And she's only a couple of weeks in. And then some other mechanisms of how PBM works: cytochrome C oxidase is activated, and then even gene transcription gets triggered. And that can be, here we go, circling back to NF-kappa B activation, because we know that that can play a role in helping to resolve inflammation. So what do you do in practice? Of course, we identify and treat the cause. So possible causes of oxidative stress, we did, I mentioned that at the beginning, but you really want to think about heavy metal exposure, pesticides, PFAS, and you can test for those. So there's a great heavy metal profile that you can use through Vibrant. And then metabolic conditions. So patients with hyperglycemia, with fatty liver, lipid toxicity is how that's viewed basically now. You want to definitely think about those patients and get their blood sugar levels better under control and work through diet to get better metabolic control for sure. Lifestyle, diet, of course. And I'm going to talk specifically about diets that have been studied related to oxidative stress. Smoking, alcohol, excessive exercise can be a problem. It can create too much oxidative stress. We've always thought about it, oh, it creates inflammation. It actually creates a lot of oxidative stress when it's excessive. But exercise in moderation is actually helpful. It helps manage the oxidative stress pathway. So that's a good thing. So if your patients aren't exercising, that can help to control oxidative stress. Exposures to UV and ionizing radiation, you would want to get that in your patient history. Inflammation, as I said, this gets really complicated trying to figure out why a patient may be experiencing inflammation. Is it from oxidative stress, or is it from other things that could be causing direct inflammation? So chronic infections, gut health, dietary, which can cause inflammation, but can also cause oxidative stress, food sensitivities. There are a lot of reasons why patients can be experiencing inflammation, and there can be genetics also related to inflammation. So not only could you have a patient who has genes that make them more predisposed to inflammation, then now we have the ability to test all these genes that tell us if a patient has like a genetic predisposition for oxidative stress too, to help us better understand what to do, which pathways to really a patient would need much more support in. So dietary risk factors for oxidative stress. These are pretty specific, what has been detailed in the literature. So detrimental chemicals in the diet, which we've already talked about, pesticides, heavy metals, xenobiotics, alcohol is considered an oxidant, lack of phytonutrients. So the phytonutrient aspect of it is really key. As I mentioned, it upregulates NRF2, which upregulates those antioxidant genes. And then we end up with a better response in terms of our endogenous antioxidant pathways through enzymatic primarily. Processed meats have been shown to be a burden for us in terms of oxidative stress. Really high saturated fat and cholesterol have also been shown to be problems. There are papers on that. High fructose. I know sometimes fructose can be a controversial molecule. High sugar, of course, in general, as I mentioned, hyperglycemia is associated with high oxidative stress, which could come from high sugar in the diet. But high fructose is definitely a specific sugar that comes up repeatedly in the literature related to oxidative stress. Gluten, good paper on this, shown potentially, like obviously definitely in celiac patients, but this particular paper was even in non-celiac patients as a potential trigger for oxidative stress. And then excess calories. So studies on caloric restriction show that the main effect, on the flip side, is through upregulation of the SIRT1 molecule that activates eNOS. So that we know that that's really important. Nitric oxide synthase and the endothelium for cardiovascular health. We'll probably hear more about that in the cardiovascular component. Here's the dietary patterns from a really nice paper published in 2021. And this was titled Dietary Patterns and Biomarkers of Oxidative Stress and Inflammation, a review of observational and intervention studies. So their conclusions on diet, it's a really nice paper to read, but what the conclusions were was that a plant-based diet was associated with lower levels of oxidative stress and inflammation. So they did find that diet to be helpful. A Mediterranean diet as well had been shown to reduce levels of lipid peroxidation and oxidative DNA damage. The DASH diet lowers levels of lipid peroxidation as well and increased nitric oxide levels. And then, of course, no surprise, Western diets were associated with higher oxidative stress and inflammation levels. Okay, finally, I want to end off with a discussion about like supplementation that you would consider for managing oxidative stress. So obviously, I think it's pretty clear you need to work on dietary components. That's always key. But then when we start thinking about adding on nutrients for management, a lot of people are familiar with antioxidants, of course, vitamin A, C, E, carotenoids, selenium, zinc. You can test patients for these levels, see what their levels are, determine whether they need like higher levels of supplementation in any of these categories. Omega-3 fatty acids, we think about, historically as a means to manage inflammation. So this is one of these cases where we have like overlapping nutrients. Omega-3s reduce the balance of saturated fat. So as I just mentioned, diets high in saturated fat have been shown to be pro-oxidant. So these long chain saturated fats specifically. So a reduction in the ratio of omega-6 to omega-3s is key here. And again, you can measure that too. But omega-3s are important with that aspect. Alpha lipoic acid, which is also an endogenous molecule, can be supplemented. Geranol is another great molecule to think about for oxidative stress. Olive oil is detailed as an antioxidant, and it's thought that it's not necessarily from the monounsaturated fatty acid portion of it, but probably due to the presence of phenols. And there's a lot of evidence and recommendations for olive oil for patients with cardiovascular disease and how beneficial it is. And it's probably the phenol phytonutrient component of olive oil that is most important for oxidative stress management. We know that is really key for cardiovascular disease management. And then some of these other endogenous molecules that we're familiar with, glutathione, of course, CoQ10, and melatonin, which we're all familiar with, but I don't think a lot of people necessarily think about it as an antioxidant. It's not, historically what comes to mind when you think about melatonin. All right. And then finally, the phytonutrients category in plants. So this is the thinking is that these may be even the most important molecules above and beyond supporting our endogenous antioxidants. These molecules, they do have direct antioxidant effects, but the indirect effects, just like I was mentioning about the upregulation of the NRF2 pathway, is what's key here. So when we think about a direct effect, we're just talking about like binding up free radicals directly from that molecule. And these like plants have the ability to do that, and all the phytochemicals in there. But what's even more interesting about these is that these indirect effects are the most important here. So if you're trying to address patients with an antioxidant, you really want to incorporate some of these different phytonutrients. There's so many directions you can go here, and that's what's really cool about plants, medicinal plants. And all of these compounds, is that looking at the whole patient profile, you can select plants that maybe would have, a better match to whatever that like patient is dealing with, whether they have more of a cardiovascular profile versus they have more of a neurodegenerative. So like, an example, I would, ginkgo could be something that you could choose as a medicinal plant for someone who has more sort of like a vascular dementia, right? Like cardiovascular disease in that respect. Because ginkgo has that affinity for the brain. Phytonutrients, lots of different options there, of course. Green tea, catechins, the polyphenols in coffee, curcumin. Again, we think about curcumin as an anti-inflammatory, but it's an excellent antioxidant. Quercetin, excellent antioxidant. And sulforaphane from broccoli. Berberine, really hot molecule right now, is also an antioxidant. So think of all the different mechanisms or conditions that berberine is good for. Also has the ability to upregulate our own antioxidant systems. And then cocoa polyphenols, patients always love it if you give them a prescription for some dark chocolate. And then of course, herbs and spices. So cloves, cumin, rosemary. So some of these can be in supplements, but a lot of these can be encouraged to add to the diet, making sure patients are using herbs and spices, fresh, dried. The more of those you get, they're so packed in phytonutrients and, give direct measurements of the direct antioxidant capacity of many of these plants and compounds. But again, it's this upregulation of our own pathways. That seems to be most important here. So I hope you gained a couple of clinical pearls through this presentation. And I think I'm glad, I think I ended good on time, that we can have good amount of time for questions. I can't hear you, Cam. I think you're muted.
Oh, there we go.
Okay,
Very good. Thank you. Yeah, so I'm able to show the questions on the screen. We just have a couple of them. So first, asking about the PBM device, good resources for that.
Yeah, so we have our unit is a Theralite device, Theralite 360. So if you just look at that, look up that device, it's a full body device, and it looks basically like a big tanning bed. And it's probably, I think it's the best one in the market. It's pretty expensive, but you can lease it and pay over time. Even they have like excellent customer service there, but it's an excellent tool.
Wonderful, wonderful. And just a reminder to anybody else who's listening, if you have questions, go ahead and put them in the chat, and then I can transition them over here onto the stage. Okay, so pycnogenol as an antioxidant.
Yep, for sure. Like excellent antioxidant. And again, like if you're dealing with sort of like vascular issues, this is where there are so many options here that you can use. And a lot of products will have blended phytonutrients, which is a good thing too. But yeah, pycnogenol would be great. I didn't have it listed in my list, but I can add that on definitely.
Very good. Very good. Okay, let's see here. Burden of methane and H2 overgrowth in the gut that is using up the hydrogen produced by the native probiotics. How would you consider that as part of the burden?
Yeah. So is that like thinking about that as a potential burden for oxidative stress? I think, is that what that question is? Maybe?
Yeah, I think I would assume that. Bernadette, if you have any other, if you can clarify that, that would be great. Otherwise, yes, as it produces oxidative stress, let's answer it that way.
Yeah, I mean, we know like gut bacteria can definitely cause inflammation and oxidative stress. So if you do have a patient who has SIBO, then they're probably having oxidative, like a excess of oxidative stress potentially, depending on their genetics, of course. But that would be another category of patient to think about.
Okay. Clarifying here, the hydrogen as a free radical scavenger, considering in that picture.
Oh, okay. So the hydrogen, yeah, as a free radical scavenger. Yeah, so like that it would actually have a benefit because it's excessive hydrogen. I don't think that that's necessarily like one of the best hydrogen, like a free radical scavengers then. I wouldn't think about that as is that like maybe it's beneficial? I don't think that would play out, but I don't know. Maybe someone on the science team could answer that better than me.
I'm going to have to look that up. I do think it's one of those that it's maybe just not used in the right context. Like, yes, it's extra hydrogen, but is it really working systemically to quench systemic radicals? Maybe not.
Yeah, like on a cellular, like that would have to be inside cells.
Right. And then the risk versus benefit of the burden to the oxidative stress. So that's something we'll have to look up. I'll do some research, and hopefully by the end of the boot camp, we'll bring some of that back in. Okay, so let's look. Let's see here. So can DNA damage from the heavy metals be reversed? And would the test show whether there's DNA or whether there's damage to the DNA?
Okay, so for sure, yes, you can test for DNA damage. That would definitely show up on the test.
Mm-hmm.
Whether you could see reversal, I mean, like you can always repair DNA. So depending on what cell type we're talking about, like those cells turn over, DNA can get repaired. So yes, that's possible.
Yes. And as far as from a test perspective, we do separate it out of oxidative stress that is specific for DNA damage versus, let's say, lipids or proteins. And so you could have those targeted quantifiable markers to be able to monitor as you then do your treatment and be able to kind of see where that marker is moving. Let's see here. Oh, kind of going back. It eats up free radicals so it doesn't get absorbed. Okay. We will continue to kind of research on this and hopefully get back to you on a question with the about the SIBO overgrowth. Let's see here. Any other questions that I missed or anybody else has? We did have one early on about copies of the slides. You will get copies of the slides as well as the recording. Any registered participants will get that. So just know that in the future, also, if you miss the live, you will also get that within once it's gone live. Okay, let's see here. Another one just came in. Once you have a baseline of oxidative panel profile, how often would you retest? Would you retest both parts, genetics and oxidative stress markers? Okay, so good question. I would say you would retest when your protocol or when your patient, when it's deemed necessary, right? So like, let's say you find the source of the oxidative stress to be heavy metals and you go through a heavy metal chelation program, then you would maybe want to retest after that. Dr. Stagg, would you agree, or do you think it would be different for different protocols?
Yeah, so I agree. I would agree fully. So I would say yes, like if you actually have like identified like a solid source of oxidative stress and you're doing some sort of treatment to address that and you've cleared that up, then you would retest after that. If I would say the majority of patients, it's going to be like multiple sources probably of oxidative stress for a lot of people. And so, a lot of times we think about tests, whatever we're doing, it's probably minimum 2 months, probably 3 months. Like that's a typical time frame to really see like cellular processes changing. Like certainly after six weeks, you can always maybe see a little bit of something, but I would say probably along the lines of 2 to 3 months. And that's kind of like for many different tests, that's kind of what I would do. In terms of genetics, like you wouldn't test that again. You would just do the oxidative markers, which you can separate those out, right?
Yes, absolutely. Absolutely. Yeah, you can separate those as separate panels. Yeah. Okay. And then let's see here. Would you have a patient stop their antioxidants before testing?
Yeah, it's a good question. Because a lot of tests are like, oh, you should stop these 3 to 4 days before. Some types of tests like organic acid testing, you could have a patient off them for like 10 days before just to see what is happening naturally. A lot of times I think you can test depending on what you're actually supplementing, test to see how they are on something. So a lot of different categories of testing you can do that way. I guess it would really depend on the patient, but you could go either way on that to determine what they should be doing. Because obviously if the antioxidants are working and then you take them off of them for a week, you probably see their antioxidant levels, like the markers possibly higher if they really need that support. Like say they have genetics where they have an oxidative burden because of like poor genetics, then they need that antioxidant support. You're going to see like, oh, it's going to look bad without it. Right? Yeah.
Yeah. And I think it really, it depends on the practitioner and like what you're trying to see, right? Are you trying to see them at baseline with, without anything in their normal diet? Or are you trying to are you looking at a retest when you want to test, like, are their antioxidants working and my protocol working and that type of thing? So it may be different for different patients or just your own personal practice preference of, what types of information you are trying to gather from the test. Okay. Any other last questions before we wrap it up today? We'll give it just another couple seconds here if anybody else has anything else. But Dr. Stagg, thank you so much. This really was nice and clear. It helped to give some really great clinical pearls, some good treatment options, and really pull together that kind of, how does oxidative stress have a role that we were missing, right? Everyone's just looking at inflammation, and we really need to be looking at the interplay between the two. So I really appreciate your time today and your presentation.
Thanks. Thanks for having me. And I think what's key here is that the ability to be able to test is so important. And we just didn't really have that before, right? Like, I know all I had was like a little like blip on an organic acids test to tell me something.
Right.
So I think a lot of people, a lot of practitioners can be using antioxidants, but you don't know, like, does your patient really like have this burden that your protocol should be heavily focused in that direction? It could make a big difference for them.
Absolutely. Absolutely. Well, wonderful. Thank you so much for your time. And thank you everyone for attending today. And we'll see you again next week.